Hello everyone, welcome to our webinar on It Is Okay Not to Be Okay. We're going to be sharing with you some extra information about what the college is doing at the moment in this COVID-19 crisis. But first of all, I want to introduce my co-panelists, and I'm going to ask them to give you a little sort of biopic of themselves as we go along. First of all, Vic.
Hi, so I'm Victoria Pegna. I am an ST7 in colorectal surgery. I'm also a council member, and I'm also less than full-time for my two children. So I'm speaking on the panel today. Great.
Stella?
Hi, I'm Stella Vig. I'm a consultant vascular and general surgeon based down in Croydon, also a council member, and just here to try and answer some questions to keep you on the straight and narrow in this very difficult time.
And then we have Lucy.
Hello everyone, I'm Lucy Davis. I'm Director of Engagement at the college and I'm helping with the questions this evening.
Well, that's great. I wonder if we could have the first slide after the introduction slide, please. Just to give you some updated information on what we're doing about COVID-19, there is an information hub specifically on the subject. Please do go and have a look at it. It's changing all the time. Obviously, the situation is changing all the time too. We've got those, if you like, pieces of information available to you. And I would like to commend to you views from the NHS front line. We're starting a blog or podcast series. And if you'd like to contribute to it, give us some inside information about the difficulties or triumphs you're having at the moment. We'd love to hear about it, and we'd love to tell all your colleagues about it too. Next slide, please. Now, this is new, and as you can see there, is going to be rolled out from tomorrow. We have, if you like, ramped up the support and advice service. This has been available some time, our confidential support and advice service with a call number, but we've realized that there may be, if you like, additional pressure on the service to give you as much advice as we possibly can. So we're there for you if you do have difficulties. What happens is you ring the number and a health assured counsellor will first of all answer the questions, and if they are related to emotional support and so on, the counsellor will help you with that. If you have a particular peer-to-peer surgical question, we have a large group of experienced surgeons who are very, very happy to speak to you about surgical issues, and we'd like you to feel free to use the service. And you can see there at the top is the number, and at the bottom is the way to get access to it from our website. Next, please. Thank you for all those who helped with our PPE testing survey. You may have seen in the news over the weekend that it was quite widely reported. Obviously, this is a hot topic at the moment. As you can see there, a third of the almost 2,000 who responded didn't believe they had adequate PPE in their trust, but there was wide regional variation. Obviously, there's a testing issue too, and most of you think that testing on a large scale is absolutely essential before lockdown can end. We'll be repeating the survey, and please help us to complete it, because as we go through the COVID crisis, we'll be seeing what trends there are, whether things are getting better or worse. So it'd be great. So to the next slide, please. I'm not going to read out all the various guidances. There they are and their dates. Keep an eye on the COVID-19 updates, and we'll have more guidance and updates for you as we go along. Next, please. And this is the main topic of this evening. It really is okay not to be okay. I think it's fair to say the college hasn't been great in the past at talking about these kind of issues, and we are upping our game, as it were, and especially right now, this is clearly something we need to help you all with. And so these issues are the kinds of things we're going to be talking about. We've had a few questions in already. If you'd like to submit a question, please do so, and as we go through, Lucy will be reading out the questions and they will take turns in answering them. So, Lucy, I wonder if you could please read out the first question.
I've been in correspondence with my colleagues regarding the situation in dentistry in Wales and the wider UK, and I'm shocked by the language and tone of messages to the extent that I'm concerned for their mental health. What should I do?
Well, we presume the tone and the messages aren't very complimentary to what's happening around them. And I think, of course, it's really easy for us to get extremely angry if we feel that we're being compromised, let down, even lied to. And so I think it's really, really important in that situation to have a buddy or a friend to talk it through with. I mean, I don't know whether that colleague has already done that. I hope they have. If they haven't, maybe there's somebody else that person is close to who they can discuss things with. It's kind of anger management, really, and anger management is partly understanding why you're angry and talking it through and seeing if there can be some resolution. But I wonder if Stella, who's been in hospital clinical management, can give us a steer on that. What do you think, Stella?
I think it's a really difficult time because the normal everyday niceties of time to try and come to a joint agreement of what needs to happen, you know, we've not had that time. So almost over a weekend, we've gone from a normal rota, normal job plans of consultant colleagues, to junior doctors doing 3 on, 3 off, you know, days, nights, and ambulatory. Consultants going to day of the week, 24-hour on-call cover from site. And so the tone that is used, sadly, has not been as easy as it normally is. And I think we've lost some of the niceties. Our responsibility as senior clinical managers is to make sure that everyone is engaged, but particularly you as the juniors who really are on the front line. You have to be engaged in what's going on, because you're the ones that are putting loved ones at risk. You're putting yourselves at risk. You're there for patient care. You're there for surgical. You can't put a surgical operation off. You have to do it. So it has to be a combined team approach in terms of what's happening. Where that's not happening, the conversation needs to be brought up with more and more senior people within the organisation. So this is a time of leaders who have been thrust into the leadership position. Some of them won't find that comfortable. If the tone is not right, there are people in the trust who will listen. There are people at the college who will listen. You have training program directors who will listen. You need to keep talking until it's resolved. But it's certainly not something that should be internalized and you think that's the only way forward.
Okay, Stella, thanks very much. Lucy, can we have the second question, please?
How do I manage a colleague who here in the department regarding the risk of or serious complications from COVID-19 and refuses to see patients face to face, yet presents to work daily?
Now, Vix, would you like to answer that? Have you had colleagues who've been scared to go into harm's way, as it were? What do you think? Is it reasonable to say they shouldn't?
I think it's a very tricky thing. I actually don't know if I've got the right answer for that. I think it's very tricky. We have that first-hand evidence of that in our department, but I think it's widespread that everybody is reacting differently. I think it's very tricky if all of you are on the front line together and you have someone that is, let's say, more scared than others, but not for a medical reason, as in that can be dealt with separately, where they're not willing to muck in and be part of the team. And that is a really tricky thing to deal with. And I think that specific question is actually asking about at a consultant level. Between consultants, what do they do? Obviously, as trainees, we potentially have, we haven't, but people are potentially having the same situation where many of us are putting ourselves on the front line and others might not want to, and that's very, very hard. I guess communication is and talking it through with your team and trying to get to the bottom of why they feel they are less able than people at the same level as them to expose themselves might be something that can be solved. But I think at a consultant level, if it's between consultants, that is a very tricky thing, and I probably defer that to you both to see what you would do with it.
Yeah, well, it is a very, very tricky question, isn't it? I think that if somebody's bleeding to death, let's say, I think most surgeons' instinct would be to rush in and try and stop the bleeding, whatever their level of personal protection or feelings of risk. I think it's the more grayer areas where there's time to think about it, perhaps, and you are aware, and I think we will become increasingly aware that the personal protection isn't available to an ideal standard. And then I think, is it a matter of conscience? Is it a matter of letting down the team or being with the team? I think there are lots and lots of really, really difficult emotional, moral, almost legal issues there, which we're going to try and develop on the COVID-19 website to help with discussions like this. Stella, do you have a view on this?
I think sometimes it's worth just putting yourself in someone else's shoes. So as surgeons, we're not naturally open. We don't normally show our Achilles heel to the wider surgical community. We normally keep ourselves to ourselves. So when we have three sets of colleagues, we've got people who are shielding because of medical reasons, as Victoria mentioned. There are people who fall into an age category where it's not appropriate for them to be on the front line. And I think as surgical teams, most of us have actually developed a protocol that protects as much as we can. There are a third group of people who are just plain scared. And Victoria, as you said, talking through, understanding their concerns, their worries. There's so much gossip about COVID. The college website is really good at diffusing those myths, but the gossip still exists. So actually understanding where that person is coming from, where the anxiety comes from is important. But also I think we need to remember that the numbers of people that have died, actually the deaths have touched different people in different ways. And you may find you've got a colleague who is very worried about being on frontline because they've lost a neighbour or a friend, and they may not have discussed that at work. So I think understanding the anxiety and actually working out a role for that individual rather than castigating them and saying they're not someone who's a team player is worth doing. It's really difficult to do that as a peer. It is much easier to do that in a management position or an educational seniority position, to actually get that understanding of what is it that's making that individual do exactly, Neil, as you suggest, which is go away from our surgical instinct, which is always to help. Something is stopping it. What is it that's doing that? And then, of course, there are some people who are just belligerent, who won't. I can tell you how we are with that at Croydon. I am quite happy to call out GMC numbers and NMC numbers of people who do not want to deliver professional expertise at this current time when it's needed.
I suppose the approach has to be similar to, I know it's not the same as a non-team player in any other situation, but you're going to get people that aren't team players, whether it's for COVID or whether it's for some other reason. And I suppose you try and follow the same kind of protocol and pathway and reach out, try and understand the source, like you say, what their anxiety is, see if you can deal with it in-house. And then it does potentially have to be taken to someone who is well versed in the kind of management side of things and can try and deal with it at a more senior level.
Okay, that's very good so far. I'm sure there'll be lots more interesting, difficult issues to discuss as we go on. Lucy, do you have another question, or shall we have topics? Fire away, please.
Okay, so feeling safe is really awful. So how can I deal with a previously sick or suspected patient?
How can I deal with a previously sick or infected patient? This is somebody with COVID.
Suspected. Sorry, is my audio not very clear?
What was the first part of the question? Can you repeat the first part of the question?
Feeling unsafe is really awful. So how can I deal with a previously sick or suspected patient?
Okay, so I mean, college advice is that you should suspect that every patient you meet in the current environment from now on is COVID positive, even if they've not had symptoms and even if they have not tested positive. So again, the guidelines relating to the appropriate PPE, depending on how PPE, depending on how near you are to the patient and so on, and then if you like, if you are still scared or terrified, then discuss it with a colleague, buddy up with somebody, maybe go to the situation with somebody else and share it. I wonder if, Vic, you have another view on that.
Yeah, so I feel I think things have slightly changed, but I think I have to say some of the briefings at 5 p.m. on the telly with Matt Hancock saying the other day that NHS workers should learn how to use the PPE appropriately and not overuse it where it shouldn't be overused. It was not a helpful comment suggesting that we're misusing it. And I think that the college's approach has been really helpful to say that we must look out for ourselves. And even if we don't know that a patient's COVID positive, we need to protect ourselves. And I think that in different hospitals, I'm hearing stories from different trainees and other levels of team members about how open and welcoming teams are and wards are to people wearing masks or gloves when you're not with a patient that's been proved positive. And I think the attitude is slightly changing, and I think people are starting to be more open to, if a doctor decides to examine a patient that's not proven COVID positive but wants to wear a mask and gloves, I think that's now acceptable. But I think it has taken a little while to get to that point. And I think there has been a little bit of stigmatization of doctors maybe and nurses or healthcare workers that have wanted to wear some form of protective equipment with patients that haven't had a positive result. And I think that's where the feeling unsafe has come from. I think that's changing now, but it's taking a while to filter through. I don't know what Stella think. You've obviously been hit very, very severely in Croydon, Stella. I don't know how it's on. Yeah.
I just think it's normal to feel scared, Victoria. I think you're right, and I think the college guidance has been very clear that if you don't have the correct PPE, even though your surgical instinct is to go in every time, if you don't have the right PPE, you should not be putting yourself at risk. But even wearing the right PPE, you're not going to not feel scared. That fear of, this is a virus that we've never seen before. It's a virus we don't quite know how it behaves. The symptoms that, the normal temperature and cough, we know that that's not the classic symptom. There are so many other symptoms that can mimic other diseases. It's like pancreatitis, isn't it? It can mimic anything that you see now. So as Neil says, every patient needs to be treated as if they're a COVID positive patient. That's the easiest way. But you are not going to stop feeling scared. One of the things to do is, we talk about every moment counts with a patient. If you're going to go and see a patient, and as Neil says, you're going in to examine a patient, is that examination going to be enough? Are you going to need a registrar to come or a consultant to come? So do you therefore not examine that patient and actually go with the most senior person who can make that decision about discharge or not first time? So actually you're not putting yourself at risk. But it is normal to feel scared. And I think we must remember that it is normal to feel scared.
Thank you, that's great. Stella, can I carry on the subject? Now, Stella has actually just herself recovered from an episode of COVID-19. She's been at home pretty ill, has got back to work in the last day or so. Just relate to us a little bit of that personal experience, if you don't mind, Stella.
I have to say, I've obviously had the mild, maybe moderate form. I have never experienced an illness like I have, and as you know, I've had surgery and all sorts before. So basically had a headache, a little bit of a temperature, and within 24 hours was just completely floored, could not get out of bed, very dizzy, back pain like I've never had before, and was constantly asleep, and I don't sleep. I go to bed very late and wake up reasonably early, and I literally could not get out of bed. The conversation about going back to work at day 8, I was determined to go back at day 8. There was absolutely no chance of me going back at day 8. I was still asleep, and I went back to work on Tuesday, which was day 14, and was absolutely exhausted, and I'm still short of breath walking around. So those who have the moderate form or the severe form need to understand that they're going to need time to recuperate. It's going to be difficult. One of the most difficult things was my husband obviously had to isolate because I had COVID, and my youngest son, and I spent the last 2 weeks absolutely fearful I was going to pass it on to them. So I've never isolated so well in my life. But
I mean, I've got colleagues recently who
it is a scary time, and it feels like a lottery, Neil. It feels like an absolute lottery. You don't know what's going to happen.
Yeah. No, sorry, I was going to say I have colleagues in Italy who have self-isolated from their families for 4 weeks from the beginning of the episode because they were terrified. I mean, obviously, it was a very high incidence of medical staff getting COVID-19, and they have only just now begun to go back to their families after 4 weeks out of action. I wonder if I can just ask you, Stella, what are the rights and wrongs of the clinical management team or even the non-clinical management team enforcing a return to work after an episode of COVID-19? Because there will be colleagues who will experience that, and they may be under undue pressure to go back before they're ready. What are the rights and wrongs of that?
So Neil, I think that's a really live conversation. I think that is happening. I think we put ourselves under pressure. Surgeons are always wanting excellence. We never want anything less than that. So if you're told you can go back to work at day 8, you expect to be able to go back to work at day 8. So you've got your own personal expectation, and I think you need to listen to your body. I think your body will probably tell you what to do anyway, but you do need to listen to your body, and you must not go back until you're ready. HR processes are beginning to make phone calls at day 8, 9, 10, 11, 12 to say, are you coming back? Personally, I feel that's inappropriate. The problem that HR have and trusts have is that our workforce is depleted across the piece, not just medical, it is absolutely depleted. So having somebody back is really, really important. But you cannot come back until you are ready. And again, if you're getting undue pressure, there are your own consultants, there are your Occy health teams, there are so many places that will support you to say that you are being bullied back to work and it's not appropriate.
Yeah. Well, I hope Boris Johnson's listening to this. He shouldn't come back till he's ready. Lucy, have you got another question, please?
Yes, I do. I've got a question that's a trainee question. Any advice on how not to feel demoralised and let down by the new ST3 recruitment system that disadvantages female surgeons and those with weaker portfolios?
So that was discussed in the last but one webinar, and obviously these are very, very difficult times, and we have to do what we can do. And our president has promised that we will do all we can to see that nobody's, if you like, application process, their attempts to get on in a surgical career are compromised in any way by the current circumstances. Now, inevitably, the usual selection process at the moment has to be suspended in some way, and we have to have alternatives. And we will again do all we can to make sure that that process is as fair and as transparent as possible. I don't know whether, Vic, you have a comment there for other training.
This was talked about previously, I know, but all I can say is that it's not fallen to the wayside. I also sit on as an invited member on the RCS Council, for example, and they are, you know, really trying their best, communicating with the Royal College and all the necessary bodies. They're all over this, trying to make sure that people are not disadvantaged, whether they're whatever gender and whatever their application and whatever level. There is a lot going on behind the scenes at the moment, and everybody is trying to make sure that people are not disadvantaged. I don't know how things will pan out. I can't see the future, but I do know that everyone is trying their absolute best to make sure that they're not disadvantaged. So that's all I can say at the moment.
So to the questioner, stick with it. Surgery is the most fantastic career. Please don't give up. And we'll do all we can to make sure that the process continues in a fair way. Lucy, next question, please.
What is the situation with diabetic staff? Can they work with COVID-19 cases?
Did you say diabetic staff with that? Yeah. Okay.
Yeah.
Stella, can you?
Yes, so the only people who, so formally to not work with COVID patients, either you have a letter that says you are shielding and or you have OcuHealth sign off that you should not be managing COVID patients. Those people have already been identified, and if you feel that you're part of that group and haven't been identified, then you need to go to your OcuHealth. If you are diabetic, there is an increased risk, but just the same as an increased risk if you're a man and not a woman. So there is an increased risk, but it's a mitigated risk, and you can work with COVID patients.
Can I ask you, Stella? I was going to ask, say you have a colleague who's been keeping quiet about their bad psoriasis and is on a super duper monoclonal antibody, which you know, they're worried there may not be all the evidence, but they're worried it's going to compromise maybe their health if they do put themselves in harm's way. What would your advice to them be?
So I think colleagues have been very, very transparent, and I think that goes back to the point earlier. When someone is fearful, there is often a reason. So there are many things that we don't discuss, and many things we keep personal. This is a time where actually those things have been uncovered, and it is a case of supporting them. So OcuHealth, occupational health, are a great resource in terms of what can or can't be done. I think we've got a duty of care to our colleagues. We do have workforce numbers. We can manage in different ways, and if we can support colleagues who need to be on the front line but not quite on the front line, so maybe they can do ambulatory care rather than ED. There are ways of managing within a team to make sure that we protect each other, and that's not just doctors, that's our staff nurses, our allied health professionals, our admin teams. There are roles for everyone in what's going on at the minute, but it's understanding what is their level of anxiety, what is their level of risk due to their underlying health condition, and how can you support them to be really valuable during this time.
Okay, good. Lucy, next question.
A question about morale. So any tips or tricks on boosting team morale? Taking cake and chocolate into work can only go so far.
Yeah, I think if half the team aren't there as well, and you're expecting them to be there, it's pretty difficult as well. Vicky, what do you think, Bex, about team morale?
I work with a particularly lovely set of registrars, and what we've found is our communication, and because we're not always together, you know, someone's always self-isolating, our teams have been reduced, so you're quite dispersed now. But we've had quite a few Zoom conversations. We are really talking amongst ourselves. Obviously there's the things like cake and whatever, and you can buy pizzas and try and create a really good team spirit. But actually I've found that trying to speak to them and talk about our fears and concerns and worries outside of the workplace, even if we can't do that in a social setting. Last night we had a whole Zoom conversation about it, and I actually left the conversation after, you know, an hour and a half talking to people that I work with anyway, feeling so much better. It's a difficult thing to say because you can't go out and do some team building, morale boosting activity, but I do think trying to remember that you're in this together and draw on each other's strengths and be more open and honest about your fears and worries and concerns, which, like Stella was saying, that's not something necessarily that surgeons do, and that doesn't always come naturally if you had to generalise. But actually, it's been really lovely for us, and we've all opened up a lot more. And it's resulted in us being a really united front, really supportive, and we're in this together. And so when management or say consultants or people have asked us to do things or change rotors or whatever, we've tried to work things out together to work out what is best for us and present them with suggestions and results, rather than do it piecemeal and not be together in this. That for me would be my suggestion. It's quite tricky at this time, I'd say.
It is tricky, isn't it? And other social media, I mean, do you have a WhatsApp group for the team, for example?
Yeah, we do. We have lots of these. I mean, they've just taken off. That's really helpful. Social media. There are lots of forums as well, lots of other social media things, reaching out to not just within your group, much wider as well. There are things like that you can do. Yeah.
Stella?
I have to agree. I think our WhatsApp at the minute is keeping us all going. As you say, you can eat so many chocolates and actually find your waist is increasing rather than anything about morale. But if we look at the public around us, schools making masks for us, they are morale boosters, and I think we need to remember that what we are doing is really important. Everyone keeps saying it, but it's really important. Remember, this is a marathon, not a sprint. Let me just turn this off. It's going to be difficult, and the more we check in on each other, the more important. I have to say, this weekend is my sister's birthday, and we're having a virtual party with a virtual DJ. I don't know how it's going to work. I will find out and let you know.
One of the people has responded from the audience, and they said, have you introduced a wobble room?
Yes.
Have you?
So we've got multiple wobble rooms, and let me just turn this off. We've got multiple wobble rooms. Some of them are faith-led wobble rooms. Some of them are just members of staff who volunteer to go and sit down. Our intensive care unit, where a lot of our surgeons have been deployed, are particularly difficult areas to work in. And there are just rooms that you can go and sit. If you want in silence, or if you want someone to come and talk to you, they will. But I think they are really, really important at the moment. I don't know, Vic, have you got wobble rooms?
Not quite that, but there is a lot that they are trying to do things like that. We're not quite as I think as far on as you are, but yes, we are starting to do things like this where I am. Yeah.
So lots of talking, communication, sharing, social media. Excellent. Lucy, next question, please.
What if our rotors are changed without us being involved, just imposed upon us?
Now that would be the kind of thing that would make me really angry, because I find that somehow a major incursion into my, if you like, my self-determination, and I want to be part of that decision making. Vix, what do you reckon about that one?
Yeah, we're actually right in the middle of this now as registrars. So what's that, and that hence this Zoom call I'm talking about. So what has actually happened is and this is my motto for life, rather than moan about it after the event's done or moan about it as an outsider, we have come up with our own rota, and we are currently presenting it to management and consultants.
Much better.
And saying that this is what we feel, well, this is the regulations, this is what other hospitals are doing, trying to explain how we've got to our suggestion, try and meet people halfway, and try and talk it out as a group. And I'd say if you can try and get whatever level you're at, or whatever, so we're registrars, but if you're core trainers, whatever it is, rather than just moan or oppose or confront people about it, I would definitely say going to them with a suggestion for a resolution is a much better idea, and I think you'll probably get a lot further, and we are literally doing that right now. That would be my main suggestion.
And Stella, I'm sure you've never imposed a rotor on anybody against their will, have you?
I have to tell you that I'm just going to put my phone away. Apologies. I can't seem to switch it off. I have to say, this time round, I actually have. I have done rotors ever since I've been an F1, a house officer. See, it always seemed to be that they would come my way. And actually, we worked through how we were going to do the rota with our registrars and the SHOs. We've given up 30 of our juniors across to intensive care. We did the rotas and we thought we had it all organised, and then we were about to publish them on the Friday night before the Monday, and actually realised that the orthopaedic rota just wasn't quite right. So we ended up redoing that rota over the weekend, and I have to say I had to go, you know, cap in hand to all the orthopaedic registrars to say, guys, this is what I'm having to do. This is why I've done it. We did engage. I made phone calls over the weekend to make sure, but it was as close as I've ever been to implementing a rota without involving the people. I've never done it before, but time is so precious at the minute and things are changing so rapidly that I think all the things that we normally do just don't always happen right now.
Yeah, I'd second that. I'd say the other thing is I think one of the issues I hear from trainees all the time across different hospitals is that they're not getting the communication from seniors or management or wherever it is, and suddenly they're hit with a new rota. I'm not at all sticking up. I'm always on the side of trainees. I'm not necessarily sticking up for you know, people at these levels, but they're under huge time pressures as well. And I think sometimes they might forget or get so bogged down in what they're having to do that suddenly they realise it's been 48 hours, they haven't communicated, and then there's these Chinese whispers that get out. So I think if you are able to, whoever it is, you know, whatever level you're at, to you can try and seek people out, find the people that you've heard that might be imposing these rotas, talk to them, open up a discussion. If they say, well, you'll know in 48 hours what the new rota will be, maybe you can push them and say, could we see how you're thinking about it? Is it possible for us to, you know, to produce our own rota, and then we can see if we can meet halfway. And I think just keeping the communication channels open, because everybody is under pressure, and I don't think people are doing things to be mean. I think they're so caught up in the pressures of corona and what they're thinking about at their level that they sometimes forget the communication would be better. But try and with them to solve that, I would say.
And if I may just jump in, the other thing to remember is that this is no longer about surgery or medicine or ITU. The junior rotas and the consultant rotas have to be at a point that if the whole surgical team goes down, I need to be able to pull in medical trainees to support the surgeons. And equally, if I lose all my respiratory team, I need to be able to give a whole bundle of surgeons across the respiratory. So this ends up being, so there is national guidance coming down in terms of how to manage the rotas. And then there is the trust-wide policy, and it depends on how big your hospital is, how many juniors you have, how can you make that rota so there is some equity and parity in the system that allows you to change people around. And actually, you know, you may be a surgeon one day and you may be an ED physician the next. It's so interchangeable at the minute.
Thank you. Lucy, next question, please.
So this is a question about surgeons who can't work because for medical reasons they're considered high risk. What can they usefully do to help without being when management are saying that they can't work in the hospital? What can they do?
Well, there's still lots to be done in terms of outpatient activity, phone calls, video calls, and so on. There's help with the organisation of the hospital, advice, the whole buddying thing, the whole, if you like, helping people who are finding it difficult, emotionally challenged, and so on. Any views, Stella, on that one?
They can do so much. I think our virtual fracture clinics have never been so wonderful. We've got, I cannot ever see us going back to doing outpatients in the way that we were doing before. The follow-up appointments can be done from home. We're using a web-based app called Accurex, which allows you to have face-to-face conversations with patients. It's quite interesting when money gets released into the NHS. So we've been waiting for computers to be used at home for feels like years. Suddenly we've got them. So those who are shielding at home have now all got work-enabled computers at home. They're working from home. It's like working from work. Our radiologists are reporting from home. There is so much that can be done at the moment, and also that professional support. So we talk about the peer-to-peer support from the college, but actually those individuals who are at home are excellent faculty to be that peer-to-peer to support locally.
Agreed. Lucy.
Okay, our trust is still not testing elective cancer cases if they have symptoms and they're only restricting it to inpatients. Should these patients be operated on?
So I think if I got the question right, they are patients who have been tested positive or about to be tested positive.
So they're not being tested. So they're elective cancer cases.
Yeah.
And the trust is restricting testing to inpatients only. Should these patients then be operated on in COVID or non-COVID sections of theatre?
Well, there have been lots of advices about cancer patients pre-surgery. So you can quarantine patients for a week to 2 weeks before they come in for surgery. There is advice about the, if you like, selective use of CT scans of the chest immediately prior to surgery. And then, of course, there is the danger of taking a patient who may not be obviously COVID positive, who has surgery, and then, of course, the general anesthesia and the hit they get from their immune suppression lights it all up, and they're desperately ill afterwards. I was hearing today of a patient who seemingly had a straightforward appendicitis issue, was sent home on 5 days of antibiotics, came back. They seemingly didn't have COVID positivity. They had an operation for appendicitis, which was now very difficult because it was all stuck, and they're still on the intensive care unit on a ventilator nearly 16, 17 days later. So there are lots and lots of complicated issues around the cancer patient pathway at the moment, and there is advice from NHS England about the general way in which cancer is managed. There's advice from the college ourselves too. We have a new prioritization document out, but the individualization of care for the individual cancer patient, I think if you're put in a position where you're being told they have to have surgery, but there's no testing available and they haven't had a clear CT chest, I think that would be the point at which you would raise your hand and say, I need to speak to a senior colleague about that. What do you think, Stella?
So interesting, London, because we're slightly ahead of the curve in terms of COVID, cancer services have been decimated. And so the Royal Marsden Partnership has put together London Cancer Hubs. The guidance within London is if you have an elective patient that needs an operation, they should be tested and be COVID negative before you operate on them. Now that doesn't follow through for the diagnostic arm of the cancer pathway. But Neil, please correct me if I'm wrong, but in terms of diagnostics, we are not doing endoscopies and colonoscopies at the moment. The trust biopsies, which are a lot of the prostatic cancers, we're holding, and there's a pause. It's the same with breast. So actually the number of patients who are having cancer surgery now are much, much reduced. And as far as I'm aware, the London guidance is that you must be tested before you're operated on. Neil, I don't know whether that's the rubric anywhere else.
Yeah, that's fair advice. So obviously the surge is happening at a different pace. So for example, I was talking to the guys down in the southwest earlier today, and they are still managing to do some elective surgery. In Oxford, they're still managing to do, if you like, selected cancer patients, but only those who've either been quarantined from an appropriate period, have been tested, and have a clear chest X-ray or CT scan of the chest. So I think part of the problem is what you can say to the question, and what you can say to your managing team is, I don't want to be left with the responsibility of this patient having had surgery and is now on the ventilator for the next 3 or 4 weeks and will probably die, because the statistics are pretty awful. Vix, a comment?
Yeah, I was just saying, I think the slight problem again is that so I think the guidelines in London, the ones you're following, are how it should be, and I think that the areas that have been less badly hit are definitely not doing the same thing. And that question from that person is, you know, sort of saying to me, I don't feel safe operating on these elective cancer patients, even though they might not have coronavirus, but we don't have a national policy about what to do about this. And so they're in a tricky situation as to where they go to challenge this. But I mean, obviously follow the guidance you've given. But the only thing I could say, the reality of that is if they feel unsafe and they feel they're not getting anywhere by talking to senior people or colleagues, is you'll have to wear the equipment when you do the operation to protect yourself and anyone else that you feel is around you, if that's the only way you feel that you can make yourself safe. I know it shouldn't be that way, but.
And there's a bigger conversation about whether the patient should have the operation in the first place. Yeah. Lucy, next, please.
So Stella, someone's quoted you, as we're treating this pandemic as a marathon rather than a sprint, what can we do now to build resilience both within ourselves and our teams in order to weather the storm?
Stella, do you want to take that first?
Shall I start with that one?
Yeah.
I think this goes back to the conversation about being a team and protecting the workforce. So you don't need everyone in every single day. The junior rotors are fairly punishing at the moment. They're 3 days on, 3 days off. We need to honour annual leave, which is very important. We need to look at consultant colleagues in terms of their time in hospital. There is a conversation about COVID load, the exposure that you have to COVID. The resilience part, as Vic says, is that social element that we're so reliant on, that being able to debrief with each other, that actually we're really struggling to get that in. And I think, Vic, your conversation about the Zoom and team meetings, just to get that social drink in the pub but in a virtual setting, is actually vital. But I think the resilience is you need the minimum workforce to do the maximum workload, and make sure it's shared as much as you can. The more we can reduce footfall in hospital, the more we can use technology to do what we're doing and conserve energy, the better. We have to remember that once this is over, and the college have already started planning that recovery phase, once this is over, we're going to have patients who've had mastectomies but not their reconstructions. We've got patients who are urgent patients who have waited on a waiting list to have their hernia repair, and actually now it's far more complicated. There is going to be a workload in the recovery phase which is going to be even harder than what we are doing now. So the resilience bit is really important. Vic, Neil, I don't know what your thoughts are.
I think obviously you have to take care of yourself. You can't just carry on day after day after day at full whack. And I think an important part of resilience is understanding that you have to have some time out, just as you've said. And the other things are important too. Think about something else other than work and COVID-19 for at least 5 minutes if you can. Try and get away from that dreaded tablet or smartphone. And I think take some exercise, whether it's brisk walking or running or a rowing machine or something like that. Get, if you like, something else happening to you in terms of fitness and taking your mind off, if you like, the current situation, just even for a little while. Vic's comments?
Nothing specifically. I have to say we've got a really fantastic consultant in ED, Rob Galloway, that's basically managing the whole hospital's rota, bar our small surgical bit. But he has had to impose rotas, but he and his team are very open to people coming to him and saying, you know what, I'm doing 3 on 3 off or whatever it is. And I found that people that have gone to him and the team managing this huge rota thing, and saying that actually this is too much, or can we do something, people have been very receptive, because I think everybody is aware how tough it is at the moment, and they'll bend over backwards to really try and accommodate people. I know that's not across the board, and I can't speak for all places, but they're all human beings, and I think that you'll find that if you do go to people and say, you know what, this is too much, is there anything I can do, is there any leeway, is there something, can I try this, I think you'll find that people will be really receptive, because they're under pressure, we're under pressure, we're all trying to work hard. But if you say it's too much, I'm sure that they'll try and be supportive, or try and put you into a different role, or meet your needs if possible, I hope.
And I think we've come to realise, and this has been the experience in other epidemics, pandemics, that in this special situation, we have to look after ourselves, because if we're not still in shape, there's nobody to help the patient. So in a sense, we're turning things on their head. It always used to be, we are here to serve our patients, right or wrong. It's not quite like that anymore. It's now we've got to look after ourselves, because otherwise we'll not be able to look after our patients.
And I think the other thing is the public purse is actually open, which it hasn't been for a very long time. So if you're finding that you're doing something that just doesn't make sense, this is a time to speak up and innovate and change, because this is a real opportunity to do things in a different way. And whereas previously the conversation's always been there is no money to do something, there is some money around. Yeah. So I think that's the other bit about building resilience is, let's do things in a different way, that we are not all. We've got European working time hours. We know surgeons work much harder than that, as do a lot of our colleagues. But actually, this is a real time to think about doing things differently. Neil, I think you're right. I think that the way that we work now and the way that we'll work after this is going to be very different. And we've got to look after ourselves, but also our families and our friends, because they all need to be around. As surgeons, we're not islands. We are supported by our colleagues and families, and they need to be around too.
Yeah, well said. Lucy.
And I suppose you probably touched upon this a little bit. I feel guilty having time off when colleagues are working so hard on the front line. What should I do?
Don't feel guilty. Is what we said. Provided you're in the rotor and you're playing your part, don't feel guilty when you've got some time out. I think it's really, really important you have it.
I think that's a recurring theme. We're on a WhatsApp group for the whole of the county that I'm part of, and it's a recurring theme about people. If you're in a hospital, for example, that hasn't been hit too badly, somewhere, and that your rota's been changed and your workload's been reduced, but actually you're having an easier time, people feel so guilty. And you just can't try not to feel guilty, because you're still working, you're still doing your best, or even if you're self-isolating, you're helping by not contracting it or spreading it or giving it to people. And I totally understand how they feel, but it's something that we have to try and work through, because we shouldn't feel guilty. We're doing our best.
Okay, thank you. A question about symptoms. So this is a doctor talking. If someone has symptoms, when should they go to hospital?
Well, if you look at the NICE guidelines, it looks as though they're nearly dead. Blue lips, very, very high respiratory rate, collapsing, falling over. I mean, sounds to me as a surgeon as though that's too late, actually. But I'll see what Stella says, having been through it herself.
I think as a doctor, if you feel that you have symptoms, you need to be self-isolating, because as Vic said earlier, if you're self-isolating, you're protecting your colleagues, and that's really important. As a patient who has symptoms, you have to follow the 111 guidance, because that's what will be given to you. And even if you go to ED, you do have to be pretty unwell to be admitted. And I think, again, the London experience is slightly ahead of the game, but it is far safer keeping patients out of hospital rather than in hospital. But if you feel unwell, you have to ask for help. I think that's the one thing we're learning about COVID. People can be absolutely fine and not absolutely fine within 4 hours. So it is one of those, if you've got symptoms, don't make a judgment. It's the GMC policy, isn't it? Don't prescribe for yourself. If you have symptoms, ask for help, ask for guidance, get external. You can't always tell yourself how unwell you are.
Yeah.
Okay.
Next, Lucy.
So there's evidence that patients with COVID-19 can transmit infections up to 20 days after getting ill. What is the logic rationale behind the advice to return after 8 days to work?
I think, Stella, you've got to answer that one too.
Oh, no! It's interesting. So the WHO guidance is 14 days. Yeah. There actually has been some data which suggests that you are still not only aerosol but fecally transmitting or exuding virus at 28 days. And I think Rosina Khan, who works in, who's an MP who also works at George's in Tooting, has actually been quite defiant to government and said, we do not understand how you can say that people should be coming back at 8 days. I think if you are well at 8 days, you're going to come back and you're going to get on with your work. But then that social distancing, working within 2 meters, wearing PPE, making sure you wash hands, all the normal things we do have got to be in place. This is, as Vic says, this is the whole conversation about if we had our way as the college. Neil, you need to tell me whether I'm saying something I shouldn't be, but if I had my way, as soon as this started, we should have been treating every single patient as if they were COVID positive. In London, we've done that over a 4-week period and got to that thought process. And I was one of those clinical managers who at the beginning of this was saying, you can't wear your mask outside of work because that's the guidance, and we all had to adhere to the guidance. That guidance has changed. I think the guidance with coming back to work may change, but if you're not well, you cannot come back to work. But I haven't got an answer to that question.
No, and I don't think anybody has properly, do they? Because we don't know. There's lots of stuff that we don't know, and advice is the advice based on what we know right now. And actually, what we know right now will be probably completely different in the next week or so. So it is a rapidly changing situation, which is why all you people out there have to keep an eye on our COVID-19 news feed to hear the very latest. It's completely impossible to give good advice about what happens after 14 days based on the current evidence, isn't it? And even wearing masks in public for ordinary everyday citizens, again, that was thought to be completely inappropriate a few weeks ago. Now everybody's considering it here in the UK. And one of the things that annoys me, and I'll be frank with all our watchers and listeners, is that evidence is good at the moment the evidence is found. But from that moment on, as we know in science, evidence changes very quickly. And part of what we have to do is to be very, very sensitive and very quick to see the new evidence and to see if we can make sure that that new evidence is put into policy.
Yes.
Lucy,
okay,
one last question.
Can I do 2?
Yeah, I do too. Why not?
Okay. So what do we think as clinicians about families seeing their loved ones in their last days, hours?
Yeah, well, we think it's tragic that they can't, and there have been some absolutely tear-jerking personal testimonies on the radio and television, haven't there, about people who haven't been able to see their loved ones before they've been taken away and so on. Obviously, again, it comes back to the social media management of it with Zooming and FaceTime and all the rest of it. It's pretty difficult to take, and it must be pretty difficult for families to not be able to see their loved ones. But Vix, do you have any comments on that?
Yeah, all I can do is say, yeah, I empathise with it. I think it's absolutely awful. I do think that the hospitals and the staff are doing absolutely everything they can to try to work around it. There's in our hospital, the ITU department have got iPads and all the kind of other ways of trying to make sure that patients don't seem like they're alone. Also, the staff are unbelievably amazing and caring at the end. And I know it's not the same as it's us that's left behind that are aware that we're not there. It's terrible, but I can see the bigger picture of why it's going on, and I think it's a really tricky situation, and everyone I think is doing their utmost to try and deal with it, sensitively as possible. But it's really hard. Yeah.
Stella, are your guys managing to do it compassionately and sensitively, or is it just getting too difficult?
It's just you're going to write a movie, you couldn't write the scenario. It is just soul destroying. And Neil, as you say, you have patients, relatives talking about seeing their loved ones going in an ambulance, and that's the last time they ever see them. But it's not only that, is then you can't have a funeral or cremation, you can't have that celebration of life that actually brings home just some peace to the fact that someone's passed. All of that is put on hold, and it is really difficult. And Vic, as you say, the ability of our nursing teams in particular to make sure that that person's passing is with dignity, and they have technology to talk to family, to be able to see the face of loved ones, is unbelievable. But the aftermath, both on the relatives but also actually on our colleagues, on us, is we've not seen, people don't die in the numbers that we've seen. We're surgeons, you know, the reason that we like surgery is that most of the time you operate, a person gets better and they go home. That's why we don't do medicine. And suddenly we are seeing surgical patients die in large numbers. We are put into ITU environments where we're seeing patients die and not recover. And it's not just people who are old. It's, you know, 50% recovery rate in ITU is what we're seeing. We've had our first patient go home, just a miracle. She's gone home from us from ITU, but it's harrowing time.
And then the last question, Lucy. You said
so so it's around social distancing. So everyone seems to be doing the 2 meters apart outside of the hospital, but they seem to forget inside of the hospital. How can we enforce social distancing within the hospital without upsetting staff?
Oh, it's incredibly difficult, isn't it? And some people manage 2 sites, a red zone and a green zone and all that kind of stuff. Vix, what do you reckon about social distancing?
The only thing I think I can add to that is to say that we're just going to have to try and empower ourselves and be brave to say, I know it's difficult, but if you have someone that's near you that doesn't maybe realise sometimes, I think, or they're coming too close, or you're examining the patient with you, or if it's a nursing colleague or, you know, doctor colleague, I think if we can try and just get over our fear of saying, I'm really sorry, would it be okay if we tried to maintain the distance a bit more? I know it's really tricky. I also know if you're going to a Met call and you've got a bunch of people around you, that's tricky. But again, if you're wearing PPE and you've treated each patient like they're COVID positive, hopefully you are protected more than if you were not wearing anything. But it's I think culturally we need to get over our inability to sometimes feel impolite in saying, sorry, would it be okay? You know, and you can do it politely, but I think communication is key. That would be my advice for in hospital.
Impossible, Stella, or manageable?
I think Vic's hit the nail on the head. We are a very polite society. We queue for buses. But this is where we have to remember we've got to look after Neil. You've said it absolutely well all the way through this, actually. We have to look after each other. We have to look after ourselves. We have to look after our family. And the person that is not socially distancing, we don't know whether they're immunosuppressed and have decided to come to work. So we have to treat each individual as precious. And as much as we can, Vic, you're right, it's very difficult to do it all the time. But as much as we can, we need to be socially distancing at every time. Same as integrity, isn't it? No one sees you. Integrity is just there. Social distancing just has to be the way that we behave.
A whole new way of going on, and some incredibly complex and difficult issues to work through. And thank you for our questioners for the questions. Thank you all for watching. We've got 2 or 3 more slides just at the end. First of all, the college wants to thank you all for doing your bit in what must be incredibly difficult times. This is, after all, the most, if you like, serious, the most challenging global health issue there has been in most people's practicing lifetimes. Nobody's had, if you like, a first bite at this cherry. Everybody's learning as we go along, and that's been part of our conversation this evening. I hope you've learned something. I've learned lots, and I'm sure there'll be lots of email traffic after this discussing some of the issues we've been grappling with, sometimes successfully, sometimes maybe not so successfully, but that's the nature of where we are at the moment in this crisis. Can I have the next slide, please? There are some more webinars upcoming for which you can register. Remember our confidential support and advice line
There are a couple of apps out there now relating to PPE. There's one called PPE. There is a social media tweeting platform called Frontline Live. If you're having difficulty getting personal protection in the next few weeks, use those. If you can't get any help anywhere else, please do speak to us. We are here to help. We want to try and help you get through this as best you can. Speak to your buddies, speak to your colleagues, speak to us. We'd like to help, and thank you all very much. Good night.
Good night.
Thanks.